I'm honored to introduce Dr. Uma Mahadevan, who is a professor of medicine at UCSF and serves as the director of the UCSF Colitis and Crohn's Disease Center, as well as director of the Advanced IBD Fellowship here. She completed her medical degree at the State University of New York in Brooklyn, internal medicine residency at Mount Sinai, gastroenterology fellowship at UCSF, and IBD fellowship at Mayo Clinic. She's a fellow of AGA, for whom she served as chair of the clinical immunology, microbiology, and IBD section, and chair of the AGA National IBD Parenthood Initiative. She's a fellow of ACG and served as chair of IBD for the 2017 ACG World Congress course and as a member of the Educational Affairs Committee. She was chair of the Crohn's and Colitis Foundation Clinical Research Grants Committee, a member of the National Scientific Advisory Committee and Task Force on Women in IBD, and co-chair of the annual Crohn's Colitis Congress in 2020. She has served on many prestigious journals, including as special section editor of Gastroenterology, and she has received multiple national awards for her research and mentorship. She's an internationally renowned expert in IBD with particular interests in pregnancy and fertility, nutritional therapies, digital health, and clinical trials. With that, I'll pass it over to Dr. Mahadevan for a talk on management of pregnant patients in IBD.
Hi, thank you, Nathan, for that introduction. Does my screen look okay? I was trying to get it right, but you just see my slides, correct?
We're seeing the whole PowerPoint view. I don't know if you were trying to show the presentation view.
Yeah, how do I don't know why it's doing that, but you're seeing the presenter view?
We see the PowerPoint view with like the toolbar and the PowerPoint. Oh, there now we see everything. Now we see everything.
Okay. Perfect. Okay, this looks good. All right. So thank you again. And it's my pleasure to talk about managing the pregnant patient with IBD. For those of you who've done call, quite often this comes up, particularly at Mission Bay, and there's someone there now. So I wanted to walk through this as a case. So the learning objectives to identify why pregnancies have higher rates of complications, to recommend preconception counseling, to prescribe appropriate medications, but also to give you an idea of what kind of research we do and where there's a possibility to participate if you're interested. So let's start with a case. This is a 32-year-old woman with a 5-year history of ileoclonic Crohn's disease. She has abdominal pain and she's referred for management of disease during pregnancy. She's at gestational week 12. She was on infliximab, but discontinued prior to conception on the advice of her OB provider. So right there is our first fail, because generally with our patients, we talk to them about the safety of their medications before they're even thinking about getting pregnant. So whenever I start a woman of childbearing age on a medication for their IBD, I will say, this is safe, this is not safe in pregnancy and breastfeeding. When you're ready to conceive, please talk to me first. So that did not happen here. Another issue is communicating with our OB providers, and there have been multiple attempts now, including a joint statement from ACOG and AGA on how we manage these patients so this doesn't happen where the medications are stopped. But now that she's stopped, she's flaring, we restarted by the infliximab when we knew she was pregnant, but there's been no response in her symptoms. She has no prior medications, no surgeries, no extraintestinal manifestations. So what would you do at this point? And in your fellows reading is this article that just came out in Nature Reviews Gastro that was first authored by Max Bronfield. And we walk through how you manage these patients. So the GI should be doing disease assessment, the maternal fetal medicine specialist, the fetus assessment, and then therapy is often a joint decision. So you want to monitor and manage their IBD, and their goal is to have at least 3 months of steroid-free remission before conception. You want to stop methotrexate, that's a known teratogen and abortifacient, and you want to avoid JAK inhibitors and S1P modulators, and that's a little bit more controversial, especially for the JAKs, because often that's the only thing between them and a significant flare. So if they're in remission, we monitor them. I usually see them in the second trimester, get labs every trimester, and then continue all their medications except the one that we discussed. And we always refer them to a maternal fetal medicine specialist, even if they're 23 years old and otherwise in good health, because compared to the general population, there is a significant increased risk of miscarriage, preterm birth, low birth weight, small for gestational age infants, hospitalization, as well as hypertensive disorders of pregnancy, such as preeclampsia. If they're having a flare, that's more complicated, and we'll get into that a little bit. So one thing to think about, and this is very distressing for mothers with IBD, but this came from the GEM project, which is in Toronto, where they assessed Crohn's disease risk among offspring of parents with Crohn's disease. And in the GEM project, they took a person with Crohn's disease and then followed all their first-degree family members who don't have Crohn's over time with microbiome and biomarkers to see who gets Crohn's. So when they looked at offspring of mothers with Crohn's, they found that if the mother had Crohn's in the perinatal period, as well as in the 1 year postpartum, versus those who developed Crohn's well after pregnancy, those offspring had a significantly increased risk of developing Crohn's disease. So there's something about the mother actually having Crohn's at the time of pregnancy. So this is more than genetics. And this has to do with, they think, intestinal permeability and some of the exposures that that infant is having. So this is a small study, needs to be taken with a grain of salt. But if the mom has Crohn's at the time of pregnancy versus getting it years down the line, there's a difference in her offspring's risk of getting Crohn's. So now that you have your patient who comes in and says, I would like to get pregnant, what are some of the predictors of who's going to flare? So if they have disease activity within 6 months prior to pregnancy, they are 5 times more likely to have a flare. So we tell our patients you need to be in remission at least 3 months prior to conception, documented, to reduce your risk of a flare in pregnancy. If they had disease activity in a prior pregnancy, they're more likely to have a flare this time. In fact, some of my patients will tell me, oh, I must be pregnant because I'm having a flare, and that's the only time they have a flare. And they're almost always ulcerative colitis patients. Ulcerative colitis is 3 times more likely to flare in pregnancy than Crohn's disease. We saw this in the Piano registry, and this has been duplicated in European registry. So particularly with your UC patients, you need to monitor them carefully. They need to be followed by maternal fetal medicine, and they need to maintain their medications. So what happens if they do flare in pregnancy like this patient? So we would do the same things we would do if they were not pregnant. So standard IBD labs. However, sedimentation rate in particular in CRP will be elevated in pregnancy. Alkaline phosphatase is elevated in pregnancy and lactation. Hemoglobin and albumin are reduced in pregnancy. So some of the markers we look at can be altered by pregnancy. It does seem that calprotectin can be effective as a marker in pregnancy. Endoscopy, this was a study out of Israel that looked at fecal calprotectin monitoring prospectively, and they found that the higher FC concentrations were associated with active disease versus remission. So fecal calprotectin, especially if you know the patient's baseline, can be predictive, but remember there are other things that can elevate calprotectin, including aspirin, NSAID use, PPI use, etc. Dr. Myung Ko, when she was a fellow, published this work looking at the safety of flexible sigmoidoscopy in pregnant women with IBD. And we looked at our cohort and found 43 women who had a procedure during pregnancy. And to do a procedure in pregnancy, these patients need to have active symptoms. Nearly 12% of them were in remission. So their symptoms were from something else. And that's why I always stress the need to have objective data in pregnancy. You cannot go by symptoms. It could have been blood from hemorrhoids. It could have been abdominal discomfort from iron. There are a lot of other things. But in 80% of patients, their treatment actually was changed based on the flexible sigmoidoscopy. So a unsedated, unprepped flexible sigmoidoscopy is low risk in pregnancy and something that can be done in the appropriate patient to help with management. We know Dr. Rishika Chugh started the intestinal ultrasound program here at UCSF, and ultrasound in pregnancy is feasible. The rectum is very hard to see with ultrasound, but everything else can be seen, except in the 3rd trimester, where it becomes more difficult as there's little room with the gravid uterus blocking some of the bowel. But intestinal ultrasound is something we have done, particularly in the first and second trimesters, to assess ileal disease in our patients with Crohn's disease, and it has been very helpful. So we go back to our patient. She has right-sided abdominal pain, but no obstructive symptoms, weight loss, difficulty eating. So these are all concerning in a pregnancy. Labs show an elevated SED rate, CRP, calprotectin, low hemoglobin. And intestinal ultrasound shows moderate inflammation and narrowing, but no stricture in the distal 10 centimeters of ileum and cecum. So she's on infliximab, she stopped it, you restarted it, she's 8 weeks later, she's still doing poorly. So at this point, you want to change her therapy. So what medications can you use in pregnancy? So methotrexate and thalidomide are contraindicated. You want to avoid mesalamine with dibutyl phthalate, which no longer is made in the United States. So azole used to have dibutyl phthalate in the coating, and that's associated with some defects in babies. Fortunately, that's not an issue. You want to avoid steroids if you can, and you want to avoid small molecules because those will cross the placenta. The medications to continue would be mesalamine, azathioprine, anti-TNFs, anti-IL-23s, vedolizumab. One thing that comes up not infrequently is cannabis. So the cannabis is used in Crohn's disease and IBD by a lot of patients. Data suggests that it helps with symptoms, but not inflammation. But cannabis use is not recommended in pregnancy or in lactation. So that would not be a choice. Believe it or not, it comes up a lot. Low-dose aspirin is something that we get asked about quite a bit, but there was a study called Aspirin that was published in the New England Journal of Medicine, which randomized patients who were at risk for preeclampsia to get low-dose aspirin, 162 milligrams daily, or no aspirin. And the patients who received aspirin had lower rates of preeclampsia. So you usually start between 12 to 28 weeks of gestation, ideally before week 16, continue through delivery. And patients at risk for preeclampsia are those with a history of preeclampsia, multiple gestations, renal disease, autoimmune disease, which is where IBD falls, diabetes, and chronic hypertension. Also, older patients with age over 35 and first pregnancy. So for this reason, we do recommend the use of low-dose aspirin in all of our pregnant patients with IBD, and our OBs here are on board. But often a question is, will these patients flare? So Amy Yu will be giving a plenary presentation at ACG on her work, where she used the data core, so use data from EPIC to identify patients who are seen in the IBD clinic and who are seen by maternal fetal medicine here. And she found, actually it's 325 patients, not 235, 325 patients with IBD who were cared for here, and about a third of them use low-dose aspirin. And she found that pregnant patients with IBD who used low-dose aspirin were not more likely to flare than those who did not. So the benefit of low-dose aspirin in preventing hypertensive disorders of pregnancy is well established by the New England Journal paper. And we know that in our IBD patients in remission that they can use this low-dose aspirin with food in their stomach and not have a significant increase of flares. What about steroids? So often, especially when biologics and things first came out, one of the ideas was that you stop the biologic, and if they flare, you just give them steroids because that should be safer, right? So we looked in our pregnancy registry in Piano, and Dami Odufalu, who was an advanced IBD fellow here and now is IBD faculty at USC, presented and published this work in Gut. And we looked at 432 mothers exposed to corticosteroids versus 1,000 who were not. And we found that those exposed to steroids had higher rates of preterm birth, low birth weight, and NICU admission. And you can argue that all goes along with active disease. There is no increased risk of congenital malformations overall, but those exposed to steroids in the first trimester did have a higher rate of oral cleft, and there is no increased risk of neurocognitive deficits or infection. We do know that gestational diabetes is increased with steroids. So this is not a great solution. We should be using steroid-sparing therapies in our patients with IBD, and if we do need to put them on steroids, we need to have an exit plan. So what about biologics? The issue with biologics is that they are monoclonal antibodies. Most of them have a IgG1 Fc component, and the placenta, beginning around week 14 of gestation, develops a receptor called the FcRn, and this binds immune globulin and actively transfers it across the placenta. 80% of that transfer occurs in the third trimester. So the babies are often born with higher levels of drug than the mother. So in Piano, we looked at this, and if you look at infliximab, you can see that at the time of birth, babies had 2.5 times more infliximab in their system than the mother. And it took about 3 to 4 months to completely clear, and by 6 months, most of it was gone. It's less for adalimumab, golimumab, and ustekinumab, where it's about 1.3 to 1.5 times maternal rates. Vedolizumab is interesting because though it's IgG1, there's a lower amount of vedolizumab in the baby than the mother. So what does it mean that the baby is born with super therapeutic levels of biologics? How does this impact their overall outcomes? So in Piano, we looked at 1,490 women with IBD who were pregnant, 379 not on a biologic or thiopurine, 242 on a thiopurine, 642 on a biologic, and 227 on both. There is no increased risk of birth defects, spontaneous abortion, preterm birth, low birth weight, or infections in the first year of life. But if they had an infection, there is an increased rate of preterm birth. There is no increase in spontaneous abortion and no negative impact of drug exposure on neural development. Interestingly, babies born with infliximab exposure actually had superior developmental milestones than non-exposed children. Infection was a big thing. If you had therapeutic levels of infliximab at birth, does that lead to higher rates of infection? And at least compared to among IBD patients exposed, not exposed, azathioprine exposed, there was no difference in infections by 4 months of life or by 1 year of life. We talked about developmental milestones, and there was no difference in developmental milestone achievement. We used a questionnaire called Ages and Stages questionnaire. If you have kids and you go to the pediatrician, you fill out all those questions like, can your child sit up? Can they throw a ball? Do they smile, etc. So it measures all of these markers of development. And there is a national standard. So all the patients in Piano had superior developmental milestones compared to the general population. That's expected because socioeconomic status is one of the most important drivers of developmental milestones. And if you're at an IBD center, chances are you're insured. However, when you compared within Piano, those exposed to anti-TNF did have higher developmental milestones even among the IBD group. Okay, so for the longest time, the US looked at things as a glass half full, and the Europeans looked at it as glass half empty, and they were recommending stopping anti-TNFs at 22 weeks gestation. Now, the problem with that is that those moms are more likely to flare, and when they have disease activity, they're more likely to have bad outcomes. And though we had the data from Piano, it took a large French study from Maxine Liu and colleagues that showed that when infliximab was stopped, the mothers were more likely to flare, and when they flared, the kids had higher rates of hospitalization. So the kids did worse. So finally, in 2022, the ECHO guidelines are now in line with the US guidelines to say that anti-TNF should be continued throughout pregnancy. They still say the last dose should be timed according to due date. That's what we did 5 years ago. We've moved beyond that, and we just continue the drug throughout pregnancy with the last dose. We try to avoid the last dose within a week of delivery. we did show in piano that there was no difference in outcomes based on the level of drug at birth in baby or in mom. Rishika Chugh, Dr. Chugh, when she was an advanced fellow, presented the data on ustekinumab and vedolizumab. The original piano data really focused on anti-TNF since that was the most common, but now we have more ustekinumab vedolizumab data and found no increased risk of adverse events based on these exposures, so we would continue these as well. Now, one thing with vedolizumab is it blocks alpha-4 beta-7, and we say, well, that's primarily in the gut. But alpha-4 beta-7 also inhibits MADCAM, and MADCAM is very important for the process of placentation, which is the placenta embedding into the uterus. Now, what's very interesting is that humans are the only people or only creatures, mammals, where the placenta actually embeds into the uterus and the blood vessels intertwine with maternal blood vessels. So that is in part why human pregnancy is much higher risk than animal pregnancy. So all the people who say, oh, you can just deliver in your bathtub, animals do it out in the field, there's actually a physical difference where you have intertwining of blood vessels between the placenta and maternal blood supply. In other mammals, the placenta just sits on top of the uterus, which is very different. So if you block MADCAM and that whole process of placentation, will you have abnormal placenta? So we did it as a proof of concept. We looked at just 2 patients, and Adam Blaisdell published this in 2022. And you can see here to the left, this is a 37-year-old woman with Crohn's disease, and she had multiple illnesses, including pulmonary hypertension. So compared to the normal control on the right, you can see how bad this looks. But the second patient was 39 weeks with ulcerative colitis, completely healthy, no other problems. Though the placenta doesn't look as bad as the one on top, you can see that it's very different and abnormal compared to a normal placenta. So is this because she has IBD, or is this vedolizumab? And we're currently in the process of collecting placentas of women with IBD with multiple different medication exposures, and trying to understand this. And in understanding what happens with the placenta, we'll also understand gestational or hypertensive disorders of pregnancy as well, and why these women are at increased risk. And this is work done with Susan Fisher's lab, who's one of the global placenta experts. So what about small molecules? So now the difference between a biologic and a small molecule is a biologic is actively transferred across the placenta. It's too big to passively diffuse. And that active transport really starts around week 14. Remember, organogenesis occurs weeks 8 to 12. That's when the baby's organs are forming. And exposure during that time is what can lead to congenital malformations. So probably why we don't see significant congenital malformations with anti-TNFs is there's no exposure in the first trimester. And the bulk of the exposure is in the 3rd trimester, when 80% of that transfer occurs. But with small molecules, they do cross, they're pills. So they will cross in the 1st trimester. And when you look at animal reprotox studies, for tofacitinib, they did see feticidal teratogenic effects in rats and rabbits at 73 times and 6.3 times the human dose of 10 milligrams twice a day. We have some exposures. Most of the time when they found out they were pregnant, tofacitinib was stopped. So you can't really say that they continued it throughout organogenesis, but no difference, but only like 24 IBD patients. We do try to avoid it, but sometimes I have continued it through pregnancy at the lowest dose. We do not recommend breastfeeding on tofacitinib because it can cross into breast milk. What about upadacitinib? Now, this is different because you actually see teratogenicity in animals at the human dose. So at 0.8 times and 7.6 times the human dose of 30 milligrams a day, there was teratogenicity and feticidal effects. So that's a big deal. So upadacitinib, I really, really avoid in the first trimester. I would not feel comfortable with that. If you had to do 15 milligrams, it's a little bit better. But again, this is far more concerning than the super therapeutic effects of tofacitinib. So for ozanimod, it was 60 times and 2 times the human dose of 0.92 milligrams. Fortunately, with ozanimod, usually they have other medications they can switch to, and that's an easier call. With the JAK inhibitors, it's often last resort and the only thing between them and surgery or significant flare. If you can, you want to stop at least 4 weeks prior to attempting conception. Okay. So now you have your patient that came in that was on infliximab, didn't work. You started her on something else. Is that going to work or not? And if it doesn't work and she needs surgery, what does that mean? Now, you'll often hear surgeons say, or people say, that the best time to operate is in the second trimester. That's often not a choice. You operate when you have to operate. The benefit of the second trimester is there's a lower risk of miscarriage, and also there's more room, because in the third trimester, it's very hard to operate because of the baby and the large uterus in there. So this study from Maria Chaparro that was in Spain looked at 44 IBD patients that had surgery over time, so over decades. And they did find that there were 4 miscarriages and stillbirths. There was a hemoperitoneum. There was significant morbidity and mortality in this study with surgery, but this is historical over 20, 30 years. When you look at more modern data from the Mayo Clinic, we don't see that same level because we have better supportive care and better surgical techniques. And these patients are usually in an IBD center and not out in the community for their surgery. So that being said, surgery can be done. We have done it in our patients with IBD with success, and often it is what they need to have a successful pregnancy. Obviously, the colorectal surgeon needs to be experienced and on board from the very beginning. Okay, so we go back to our case. She's seen by maternal fetal medicine, started on aspirin 81 milligrams a day, and started on ustekinumab gestational week 15. So ustekinumab is week 0 and then every 8 weeks. So she got her IV at week 15, and then week 23, she got week 8, and week 16 dose of ustekinumab would be gestational week 31. Do you give this dose? Yes, absolutely. Her next dose would be week 39. Do you give this dose? No. That's 39 weeks gestation. You would just wait till after delivery, and often our patients have planned induction at 39 weeks anyway, so she would get it afterwards. So I give it all the way up until 1 to 2 weeks before their due date. She responds, is in clinical and ultrasonographic remission by week 25. She wants to know if she can breastfeed. She wants to know if she can vaccinate the baby. I will also say, with respect to mode of delivery, unless the mother has a rectovaginal fistula or active Crohn's, it's really between the patient and the OB on mode of delivery. If a patient has an ilioanal J pouch, often we'll recommend a C-section, but again, that's more optional than if they have active fistula or rectovaginal fistula. What you don't want is an extended delivery uncontrolled with tear, because these patients have significant risk of incontinence and also fistula formation with damage. Okay, so I'm going to pause for a second there. So when we look at breast milk, can you breastfeed when you're on a biologic? So the answer is yes. Becky Matro, when she was an advanced fellow, did this work and published it in Gastro. When you look at breast milk and you collect it you give the dose of infliximab and you collect breast milk at 1 hour, 8 hours, 12 hours, 24 hours, 1 week, up to 2 weeks from the time of dose, you find that all of the biologics do have some transfer, but the rates are really small. The peak in that 2 week time point was 0.74 micrograms per ml or so for all of these. So it was very, very low levels detected. And when you think about what crosses in the placenta, on the day of birth in the placenta, from placental transfer, the infant serum can have levels of 14. So 0.74 is really nothing as a one-time thing over the course of a week after a dose. So we do recommend they continue to breastfeed while on their biologic. We found that there was no increase in infection based on breastfeeding and no impact on milestone score. And another issue was the small molecules. We do not recommend breastfeeding on small molecules because those will transfer in breast milk and you're taking them every day. So it's a daily dose and there could be negative impacts. So we do want to avoid that. What about vaccine response? So we looked at this as well in piano and found no difference in vaccine response rates across different biologics for tetanus and Haemophilus influenza B. And so that was good news. And so we do recommend they get all inactive vaccines. We recommend that if you're on a biologic, there should be no live vaccine for the first 6 months of life. And the only live vaccine we give in the US is rotavirus. Now, despite that, 40 of our patients received rotavirus despite being on a biologic, and there was really no adverse events that came out of that. So our recommendation is still not to give rotavirus, but if they get it, it's not a big deal. And maybe we will change the recommendation that these babies can get rotavirus. There's now some data out of Canada as well supporting this. And it's probably over caution to not give the rotavirus. Definitely at 6 months, if they need to get an MMR early, that's fine. In Europe, they recommend waiting a year, but there's really no data to support that. Okay, so the patient delivers a healthy baby girl by vaginal delivery and planned induction at week 39. And you want to recommend to your patients that they be in remission on appropriate therapy prior to pregnancy. You want to continue their biologics throughout pregnancy. The US and ECHO guidelines are in agreement. You want to continue small molecules through pregnancy. I'm sorry, you do not want to continue small molecules throughout pregnancy. You want to avoid that, and you do not want to give it during lactation, but biologics can be continued during lactation as well. If you have a pregnant patient with IBD, we'd love to enroll them in piano. There must be 18 years of age, pregnant, have IBD, and live in the US, and you can refer them to our website or our email, or certainly just email me with their information. We continue to enroll with the focus on small molecules and the newer biologics. And with that, I'm happy to take any questions that anyone has. It's a very quiet group.
Uma,
Hi, Dr. Mahadevan. Oh,
Okay.
all right, go ahead.
Yeah, thanks. Just quick question about ozanimod. My understanding is that it has a longer half-life compared to the JAK inhibitors. So is that something that you typically stop further out than 4 weeks?
Yeah, I think that we have so few people on ozanimod, it doesn't come up that much, but I would agree that you would maybe consider that as 3 months because it does have a longer half-life. And usually with ozanimod, you're transitioning them to another medication and not just off like you would a JAK inhibitor. So in that setting, it definitely would be at least 3 months.
Great, thanks. I think Christina had a question as well.
Hi, Dr. Mahadevan. Thank you for.
Oh, you put yourself on mute.
Oops, sorry. Thank you for the talk. My question was like, in that first patient who was on infliximab and then stopped before pregnancy, got pregnant, and then like seemed to not respond to infliximab. Is there anything to do with like the physiologic hemodilution of albumin like during pregnancy and how albumin can predict pharmacokinetics and infliximab? So in that case, well, do you see where someone like even continue infliximab, but because of the albumin changes, their response changes? Does it make sense to increase the dose or decrease the frequency at all?
Yeah, no, that's
switching?
a great question. So in general, we do not. In general, we do not change the dose of infliximab through pregnancy. So for example, if someone's on 5 milligrams per kilogram based on a weight of 70 kilos and they gain 10 kilos in pregnancy, we're not increasing the dose based on that. We continue at the current dose. So even though the albumin changes, the volume of distribution changes, and their levels that tend to be similar to prior to pregnancy, and some studies have suggested their levels go up, not down. So in this case, we would have checked our level to make sure it was okay and adjusted if needed.
Thank you.
There is a question in the chat. Do you advise oral contraceptive use in patients with IBD for clotting risk? So that's actually a great point. For all women, not just with IBD, the preferred contraceptive is progesterone based, so like an IUD or implant. And the reason for that is twofold. One, it's more effective because you take out human error. And two, without the estrogen, you have lower rates of blood clots. So for women with IBD, who may be having issues with absorption, who may need to take antibiotics or other medicines that can interact with the oral contraceptives, and IUD or progesterone-based implants is advised. But particularly for those going on a JAK inhibitor, we really recommend that because being on an oral contraceptive, being a smoker, those can increase risk of blood clots. All right. Anyone else? Is anyone out there? All I see are like names. Well, all right. Nathan, if there are, hi Ruse, thanks for showing your face. So if there are no other questions, enjoy the rest of your day.